Hi, everybody. Thank you very much for joining us here on Newsworthy. My name is Anubha Bhonsle, and the focus of this conversation is to continue the thread to help you understand all about drugs, treatments, and therapies that work in the treatment of COVID-19 and those who don't. As we all know, the guidelines are changing constantly. What was once considered a drug or a treatment that may have some efficacy may not be true now. So in this conversation, I'm bringing in Dr. Lance Pinto. He's a pulmonologist. He's also a consultant respirologist at the Hinduja National Hospital and Medical Research Center. And Dr. Pinto, I really appreciate you sparing time in this sort of very busy schedule to help us understand some of these drugs and treatments. So thank you for your time.
Thank you for inviting me.
Dr. Lance, I thought we could start by putting out caveats and disclaimers for our viewers, since we're going to talk about perhaps specific drugs and treatments that work or don't. Is there anything our viewers should know as they consume this information?
So a lot of what we are saying will probably be related to what the international guidelines are, what is generally accepted practice all over the world. Guidelines, of course, keep evolving. So, the local context needs to be taken into consideration. And maybe, things which were in the guidelines earlier will change eventually. So I think everything has to be taken with a balanced view, and you should check your local guidelines all the time as well.
Fair enough. So check your local guidelines. This is obviously information as of this hour, as of this time. And as we do know, guidelines are constantly changing. Dr. Pinto, to kick it off, in one of the previous videos that we did, we went almost sort of drug by drug and therapy by therapy with Dr. Priya Sampath Kumar as to what works, what doesn't, what is being irrationally used, and the impact of this. So to kick off our conversation, what would be your list of drugs, therapies, or the treatments that do not work for COVID-19 in the treatment of COVID-19 as of this time?
So I think when you talk about irrational therapies in the early stages of COVID, there is a kind of inclination to do something, and in the later stages of COVID, there is an inclination to do everything, right? I think so that these are the two ways in which you can look at it. And in the do something category come drugs like azithromycin, ivermectin, there's favipiravir, there's a whole bunch of antibiotics that people try for some reason. There's a whole bunch of vitamins which are being given, a lot of which don't really have any scientific evidence that they work. I think that's the initial stage where you have a prescription given by a general physician or your family doctor, which often includes a whole bunch of drugs. In later stages, a lot of the prescriptions come from a sense of desperation that your family member or your loved one is not doing well, and therefore you want to do every single thing possible to kind of try and save the person. And again, we empathize with where this comes from, but this is the stage at which the remdesivir hunt, this frenzy of getting remdesivir from somewhere comes. Drugs like tocilizumab, itolizumab, drugs like baricitinib these days, plasma therapy. All of these come into play. Now, all of these are not unproven. So tocilizumab may have a role in a certain circumstance. There may be nuanced situations in which some of these do work. But this rush where everyone assumes that remdesivir is a life-saving drug, for example, I think we know more than enough about remdesivir to know that it doesn't save lives. We now know that plasma for sure doesn't save lives. So I think this is where the second round of irrational therapies comes into play. There are constantly newer drugs making an appearance, right? There's bevacizumab, which has made an appearance in this space now. And I think we need to do our job to kind of spread rational use. Steroids, in fact, are the only possible life-saving drugs that we have for COVID. Fantastic drugs when used when a person's oxygen levels drop, but really bad drugs when used when the oxygen levels are fine and given too early in the disease. So steroids make an appearance in both places, but they're extremely rational when used in the severe situation, very irrational when used early on just to treat a fever or for some trivial reason.
I think you bring us to a point where it would be helpful for perhaps all of us to understand sort of the trajectory of the COVID-19 infection, and at what stage could we expect respiratory damage of any kind, and then the steroids come into play.
So most individuals who get infected, once they get infected, will have the usual symptoms that we identify with a lot of respiratory infections. So there's a fever very often. Fever is probably the most common symptom that most individuals will experience. There's a sore throat, runny nose, loss of smell, loss of taste. Some people have a little bit of diarrhea. Um, these are the broad symptoms that, the feeling of lethargy, malaise, feeling that something is wrong. These are the broad symptoms with which people initially present. So that's the stage at which most individuals will go ahead and get themselves swabbed, get themselves tested. Now, when the swab comes back, when the test comes back, very often the only symptom you will still have is fever or one of these initial symptoms. Yes. The oxygen levels tend to be rock stable in the first week because the virus has just kind of infected you. Sometimes it goes down into your lower respiratory tract, which is why you'll have a mild cough at onset. But usually in the first week, usually in the first 4 or 5, 6 days, your oxygen levels remain absolutely stable because the virus is just trying to gain a foothold. At the same time, your body is launching an immune response to try and fight off the virus. And this immune response, for a majority of individuals, will be all that it takes to fight the virus. So a good 80 to 85% of individuals, towards the end of the first week, start feeling better, the appetite comes back, the sense of energy comes back, the fever starts settling down a little bit. And that's the end of the COVID experience for them. They just move on in life, 2 weeks of isolation, and you just move on in life, right? So for a good majority of individuals, your body takes care of the virus in the first stage, in the first week. Now, in a small proportion of individuals, which is somewhere between 15% or so, towards the end of the first week, despite the virus possibly having left the body or viral fragments being left in the body for some reason mounts a very strong immune response. So the immune response is out of proportion to the problem, which is why that immune response, which is pouring out a lot of antibodies, a lot of cells into the lungs, floods the lungs, and therefore your oxygen levels start dropping. So this is an unfortunate situation where the body is actually trying to do good but is doing harm, right? It's a hyperimmune response. And this is the stage where we're really concerned. 9 out of 10 individuals who don't do well will not do well in this stage, the second week stage, where the immune response is out of proportion. And this is why immunosuppressive medication that lowers your immunity, such as corticosteroids, have a role in this stage, because you're telling the body, listen, the virus is probably exited, but this is the stage at which we need to get this immune response under control, because the immune response is what is causing damage. If you go through this stage, some individuals, of course, will get admitted, will possibly go through a stormy course, at the end of which you may have some scars left in your lung. And that's possibly the third stage of COVID, where the virus has come and gone. Your body, for some reason, launched an immune response which is out of proportion. That immune response and the virus both together cause the lungs to be damaged to a certain extent. And then there's a phase of recovery. Now, with the over 1 year experience that we have, we've realized that most individuals, even though they have reasonably severe COVID course, most individuals still heal gradually over time and return to somewhere close to the level of activity that they were at before. It's just a small proportion of individuals who maybe for the rest of their lives will have to lead a limited life. So I think that's the reassuring part, which is why, again, a lot of drugs which are being tried at this stage, we call them anti-fibrotic drugs, again being prescribed a lot these days, haven't been proven for COVID yet, and possibly are not necessarily in the majority of individuals who will heal by themselves. So I think these are broadly the 3 stages.
In your experience, Dr. Pinto, at what stage is sort of the overprescription or the irrational use of steroids taking place? And I'll follow that up later with Black Fungus, etc. But at what stage do you believe the irrational use is happening?
So unfortunately, we are seeing a lot of steroids being prescribed very early on, and I think this is a complex situation in a complex environment in which people are doing this. So what my understanding, or based on the second opinions that I've given to individuals, is that you usually have somebody who's young or somebody who's, say, in their 30s and 40s. People at this age group generally tend to mount a very strong immune response because your body's immunity is robust. As you get older, your body's immunity wanes, which is why older individuals do not tend to have a very strong fever. They tend to have 100-ish fever. This is, of course, a broad statement. There are going to be exceptions to every rule. But younger individuals tend to have this 102, 103 fever on day 1, day 2, day 3, day 4. And this makes them very anxious. So coupled with this fact that a lot of people give them a prescription of say 8 drugs or 7 drugs. So there is this sense of despair which sets in on day 3, day 4, saying I've been having 7 drugs. Today is day 4. I still have a fever of 101, 102. Something is clearly wrong and something needs to be fixed. And I think this anxiety possibly nudges the physician towards, trying to fix it in some way. And maybe the physicians themselves are a little anxious at this stage because they see a lot of their peers as well, prescribing steroids at this stage. Now, the problem with that is usually, even in this group category of individuals, in this group of young individuals, that fever sometimes can be prolonged, but it's not usually accompanied by a drop in oxygen levels for the majority of these individuals. So that fever is more of a nuisance fever. It just goes on and on, sometimes for up to a week, sometimes for up to 10 days. But individuals very often will not drop their oxygen levels. And that's really not an indication to give steroids. So we are very clear in the medical literature that steroids work or save lives only when prescribed when the oxygen levels actually drop. If you try and, in fact, the study which proved that actually looked at the category of individuals in which steroids were given when the oxygen levels did not drop and found that it potentially led to worse outcomes. So you actually potentially could do harm, right? And this day 3, day 4, when the fever doesn't settle, I mean, the best drugs in the universe to bring down a fever are steroids. We know that, that's fairly straightforward. But unfortunately, when used in that situation, it can cause a lot of harm as well. So when the body is trying to fight the virus, you are actually suppressing the body's immunity and letting the virus multiply. So that's the stage where, you really don't want to prescribe steroids. And unfortunately, they are getting prescribed a lot.
They are getting prescribed. And I think there is a fair amount of reportage also coming in with sort of doctors being in this very tricky situation and also feeling the pressure, as well as sort of, as you're very rightly saying, people trying to sort of bring in everything they can in this treatment. Dr. Pinto, we now have a whole host of reports of black fungus and the direct linkage to this overprescription of steroids. In fact, the center writing to states, many of the states, and asking it to be declared an epidemic. How do you explain this irrational use of steroids to black fungus?
So I think there are 2 separate issues that we are speaking about. One is the early use of steroids, which can actually cause the worsening of COVID-19 itself. The viremia worsens, the virus itself leads to more damage. The second is the prolonged prescription of steroids or the high dose prescription of steroids. So either you're giving steroids for too long, for up to a month, say, because you think that you need to taper it gradually over a period of time, or you're giving too high a dose of steroids. So the dose which was used in the recovery trial, which is the largest trial which has proven to us that steroids work, the dose that was used was 6 milligrams of dexamethasone once a day for up to 10 days. They didn't even say everybody gets it for 10 days. They say, you stop it earlier if the person's doing well, you can give it up to 10 days. Now, if you look at the conversion factor, the equivalent of that, it turns out to be about 32 milligrams of methylprednisolone or 40 milligrams of prednisolone. So that's what's recommended. Now, if you think that because a person is having severe disease, therefore they need double the dose or triple the dose, that's not really proven. So maybe there are some trials which are looking at double the dose, so 6 mg twice a day versus once a day. There are studies being done, but clearly that's the maximum you should touch. Unfortunately, we are seeing people getting higher doses of those steroids, number one. Number two, this belief that you need to taper it. So if you give steroids for up to 10 to 15 days, you really don't need to taper it. You can just abruptly stop it. Your body resets. Now, a lot of individuals, unfortunately, are given steroids for a month, month and a half. So that's a prolonged use of steroids. I think it's the dose and the duration of steroids which possibly contribute to the black fungus. But we also must take a caveat along with that. So the black fungus is not just steroids, right? It's steroids combined with very often with high blood sugars, because individuals with diabetes, even in the absence of steroids, are predisposed to invasive fungal infections. It's also the virus itself. So we know, for example, post-influenza, aspergillosis has been described. So aspergillus is another kind of fungus which invades into the lungs. And it has been reported post-influenza where steroids are not used. So the virus itself probably predisposes you to the black fungus or to invasive fungal infections. So the virus, steroids for a prolonged course or given in high doses, high blood sugars, immunocompromised conditions. So if you have chronic liver disease, you have kidney disease, if you're on cancer chemotherapy, I think it's kind of this environment in which your body is severely immunosuppressed, in which the fungus takes a foothold.
I think so. That's sort of a complete summarization and really helps. But just to summarize purely on the point of steroids, you're warning people who are watching to against the early taking of steroids, the prolonged use of steroids, and the high dosage of steroids, and obviously taking all of this in consultation with your medical practitioner, your clinician.
Absolutely, and I think it cannot be emphasized enough that people need to make sure that their blood sugars are well controlled as well. And COVID as a disease itself causes fluctuation in blood sugars. Most infections do. If you're going through an infection, your body's natural defenses, it's like a fight or flight mechanism, right? The body figures out that something is wrong, so it wants to pump up your reserves, and therefore your sugars tend to go up. So just the disease itself can cause your sugars to go high. So please make sure that your sugars are well controlled.
Okay. Dr. Pinto, I want to move on to CT scans, and I know you've sort of written a lot about it. Again, reports of people sort of suffering from respiratory damage, suddenly recovering, and sort of, getting a CT scan. I think the simple question is, when do you believe a CT scan is absolutely needed for COVID-19 patients? And is this a call people should be taking on their own?
Definitely no. I don't think it's a call people should be taking on their own because, so to make the argument that CT scans are dangerous is wrong. So, I mean, most of us use CT scans on a daily basis for a lot of different conditions. So when used in the right circumstance, I don't think we should overthink the radiation exposure. If it's adding value to a diagnostic algorithm, by all means, get a CT scan done in life in general, right? Now, for COVID-19, unfortunately, I don't think it adds much value to the diagnostic algorithm for multiple reasons. Number one, when it's done early in the disease, it might look reassuring, but those things can change rapidly. So if my CT severity score is low at onset, there is no reason to believe that it will stay low. It can deteriorate rapidly. Number two, when the oxygen levels are low, your CT scan is going to look bad. So you don't need a CT scan to validate what a simple oximeter is showing you, right? Number three, is there a way to predict who is going to go in which direction based on a CT scan? Unfortunately, no. So there are, from a research perspective, people that have looked at certain features that if a CT scan looks in a particular way, a person is likely to deteriorate. If a CT scan looks in a different way, maybe a person is not likely to deteriorate. And if that becomes standard someday, if we get that level of finesse where we can look at a scan and therefore realize, who needs to be kept on the radar, who can be reassured, then it would be useful. But unfortunately, we're not there yet. So most of the time, CT scans are not being used to prognosticate, to tell people, listen, your CT scan looks not so good, so watch out. They're just being used to give people a score. That score either reassures them or scares them really badly. So some individuals whose oxygen levels are absolutely fine get a scan done. The scan is somewhere in between the severity score spectrum. And, they get very fearful looking at that number and say, oh, this means that I'm going to do badly. This means that I need to get hospitalized. This means that I need to get a whole bunch of intravenous drugs, which is not true. That CT scan at that point of time might look a little bad, but maybe, down the road, it's going to heal very well without any intervention whatsoever. So to answer your question, in what circumstances would we do it? Number one, if you have symptoms which are classical for COVID, but you have 2 RT-PCRs which are negative. So then you would want to look at alternative pathologies. So somebody having a cough, RT-PCR negative, is it a pneumonia of some other kind? Is there something else going on in the lung that we are missing out on? Yes, we would do a CT scan at that point of time. People ask us, what if I'm in the middle of nowhere and I can't get an RT-PCR? Should I get a scan? My answer to that would be, number one, in such a situation, also CT scans have a sensitivity which is highest around day 5. So don't do it on the first day of symptoms. Do it maybe on the 5th day. If your RT-PCR has a lag of 5 days and you're going to get a report in 5 days, you might as well wait for that RT-PCR in 5 days, then get a CT scan done 5 days down the road. And really, it cannot be emphasized enough that 999 out of 1,000 times, nothing bad is going to happen for the initial 4 to 5 days. So if your swab is delayed for 4 to 5 days, assume you have COVID, isolate yourself and wait for the swab report.
You wouldn't recommend a CT scan for people who have got COVID, recovered from it, and they've been prescribed one to sort of see any lung damage and things that they should watch out for in the future.
So I think as human beings, we always like to, we love numbers, we love something which is objective, we love to see things, we are very visual. Now, if I had a fantastic drug which, would cure this fibrosis that we see on the scan, then, maybe it would be worthwhile. Do a scan, say, oh, you have fibrosis, I will give you this fantastic drug. You don't have fibrosis, great, this is reassuring, move on in life. The unfortunate part is, what am I going to do with that information? That information leads to anxiety. That information leads to people constantly worrying about their health, wondering whether their lungs will get better. One CT scan will lead to the second CT scan, because if your CT scan is not up to your satisfaction, you would want to do another, because we are curious. We want to know what's happening in the lungs. So again, that's one of the reasons why I don't see it adds any value except making a person anxious. The caveat also needs to be mentioned that scans for any respiratory disease, scans take up to 3 to 6 months to normalize. So if you do it too early, you are not going to get any value from that scan. So if you've gone through severe COVID, for example, if you've been hospitalized, you needed oxygen, if you do a scan 1 month down the road, I can tell you right now itself that the scan is nowhere going to be normal. It's going to be nowhere close to normal. It's almost 100% going to show a reasonable degree of involvement. But what does that mean? What if everybody with that kind of a scan is going to have a normal scan 6 months down the road? So why waste a scan? So in that context, I think you have to think about the radiation exposure. Is it adding any value for that radiation exposure?
Okay, fair enough. So I think in that scenario, the risk versus benefit gets very, very clear. The next set of questions, Dr. Pinto, have really come from people, they've come on our various platforms. And before I ask that question, I sort of must put the disclaimer: smoking is injurious to health, smoking is bad, and we should sort of continuously continue to maintain and put that disclosure even as a ban. What is the COVID-19 protocol for smokers?
So individuals who smoke, there was a reasonable amount of literature initially which said individuals who smoke for some reason tend to have lower rates of infection than individuals who do not smoke. But if they do get infected, they tend to have a more severe disease than individuals who do not smoke. So, number one, that information is literally playing the roulette, right? You're literally playing the odds. You're saying that I will continue to smoke because my odds of getting infected are low. But given we're in the midst of a pandemic in which your the background odds of getting infected are so high, if you do get infected, you're going to have a very severe course. So, I don't think so. Intuitively, one would not smoke based on that information. However, even to that, there is a caveat now that a couple of the large studies, at least in which this finding was reported, had ties to the tobacco industry. So I think there was a reasonably famous article which claimed this, which was retracted by the journal because the authors had ties to the tobacco industry. So let's take everything with a grain of salt. And COVID or no COVID, there are 1,000 other reasons to not continue to smoke. So I think this is a good cue. This is a good cue from nature, which is nudging you towards the direction of giving up smoking. We have some really, really good drugs which are available to help individuals quit. I run a smoking cessation clinic at my hospital. And I think this is an excellent time to consider giving up smoking for multiple reasons.
Dr. Pinto, what about smoking habits sort of affecting the vaccine efficacy? Is there at least some sort of prescription that people who do smoke should at least stop doing that before and after they've taken the COVID-19 vaccine?
So not to the best of my knowledge. Maybe I'm not updated on the literature, but to the best of my knowledge, I don't think there are any protocols before and after getting vaccinated. To just put it out there, smoking is a risk factor for blood clots. We know that, because it causes your blood to get more dense. It also causes, it affects the blood vessels in a way that you may be more prone to blood clots. And given this extremely rare possibility of blood clots with the vaccine, maybe the combination of the two could be injurious. But this is in the realm of speculation. I don't think there is any science to this out there yet, but it's something worth thinking about.
Fair enough. I think one more question that came in was from people who suffer from asthma or bronchitis. And the question was, can we take the COVID-19 vaccine safely? Everyone is saying yes, but with a caveat, as long as we do not have a severe allergic reaction to any of the ingredients. And, the person went on to say that, of course, if you have a doctor on call, you can ask, but how am I supposed to know if I am allergic to a compound like, and the person's listed the entire list: L-histidine, L-histidine hydrochloride, monohydrate, magnesium chloride, hexahydrate, in just Covishield, for instance. So both these vaccine companies have put out sort of, these disclaimers and caveats, but how is an average citizen supposed to know that you could be allergic to any of this?
So a couple of things. I think risks have to always be balanced with potential benefits, right? So you always look at what is the potential benefit of something and then weigh the risk against it. So in the midst of a surge, for example, right now, your probability of getting infected is extremely high. You also need to look at, if you get infected, what is the probability of you having moderate to severe disease? And that's based on conventional risk factors. So if your lungs are already weak, you have lung disease, if you do get infected, the probability of you having moderate to severe disease is higher than the average person. So therefore, your risk profile is a little higher than the average person if you have lung diseases like asthma, chronic bronchitis, etc. What about so that's potential benefit, right? So potential benefit of getting the vaccine is that you lower those risks which you inherently have by virtue of having these diseases. Now, what are the risks of the vaccination? So I think that's a fair question. How am I supposed to know whether I'm allergic to one of the ingredients? So this is a situation in which you then take solace from the available data on the people across the world who've received the vaccine, right? So if you look at incidences of allergic reactions across the world, they are minuscule. They are extremely, extremely rare. The more severe ones that we're kind of worried about, like anaphylactic reactions, tend to happen in the first half hour, which is why wherever you receive it, generally they will make you sit for half an hour. They will usually have all the facilities on board there to handle an anaphylactic reaction. So again, if you weigh all the potential benefits, you look at the potential for harm, which is minuscule based on what we know, based on the number of people across the world who've got the vaccine. I think the risk-benefit ratio clearly sways towards the benefit side. If you have reasonably moderate or severe allergies, if you've had anaphylaxis in the past, maybe you should choose to get the vaccine in a hospital setting rather than get it in a community setting. That's the advice I would give you.
Dr. Pinto, I do know you do work around sleep apnea as well, and there is a question about post-COVID insomnia, and is that a real thing?
So that is a real thing, and again, it's not unique to COVID. A lot of viral infections can cause post-viral syndromes, and these post-viral syndromes include this fatigue, so a lot of my patients come back to me and say, I wake up feeling full of energy and then I suddenly crash at 2 o'clock. I feel like I can't do anything. I have to go and lie down for some time. The brain fog that people describe, suddenly not being able to remember names, remember people, suddenly forget about appointments that they have, is commonly described. Disruptions in the sleep-wake cycle, insomnia, are also problems that have been reported. So a lot of neurological, or you call neuropsychiatric adverse effects or post effects have been described for COVID-19 as part of long COVID. And, some of it is also related to the fact that going through COVID is possibly extremely stressful. So we know that the incidence of post-traumatic stress disorder was reasonably high after the original SARS pandemic as well. So if you do think that some of it, so if you see other signs of depression as well, so if insomnia is not taken in isolation, so along with insomnia, if you feel that you're having mood swings, you've lost your appetite a little bit, you're not as social as you used to be, you want to go into a corner and be by yourself, maybe you should consider seeing a psychiatrist or seek help when it comes to mental health, because the insomnia might just be a symptom of an overall depression or an overall post-traumatic. But that being said, insomnia can also happen in isolation. But again, we look at insomnia very often as a symptom rather than the disease itself. So only when you're absolutely convinced that it's not a symptom of something happening, should you look at pharmacotherapy, should you look at aspects that need to be changed. And simple things like, avoiding caffeine close to your bedtime, exercising in the morning rather than in the evening, not having backlit devices in your bedroom like televisions, not using your cell phone, not using your iPads for a good 2 to 3 hours before going to bedtime. I think those would be the first steps to try and reset your clock, which is what we call sleep hygiene. If despite that you're struggling, then there are simple things like melatonin, for example, which have been used in this setting and which may be useful. I would caution against the use of sedatives, because again, they're something that people get hooked onto and then become difficult to wean. So if you're getting onto sedatives, make sure that you've ruled out all of these things that I've just mentioned, and they should be used as the drugs of last resort.
Fair enough, Dr. Pinto. I've taken a whole lot of time and you've answered all of these questions, as basic and granular as they are. Just sort of at the end, there are guidelines that are changing every day. There are press conferences, there are government statements, there are state statements, there are statements, of course, by medical practitioners. Just sort of as an average citizen, and the average citizen who obviously is privileged enough, has access to social media, has access to all this information. How should an average citizen make a distinction between communication that is meant for doctors and health practitioners and communication that they should, they should pay heed to or they should navigate? How do we actually differentiate some of that?
I think one of the things that needs to be said is that guidelines are living. They are not written in stone, especially for a disease like COVID-19, which is very new. So science evolves as you get more and more information, as more and more studies are conducted. So the fact that some of us may be recommending things today that we didn't recommend last year, or we are dissing things today that we recommended last year, is not a reflection of the fact that your doctor is trying to con you or your doctor doesn't know anything. It's a fact that worldwide people are learning along the way. Hydroxychloroquine was like this magic drug once upon a time. People wanted to import it from India. India exported it to the US. It was at that level that people thought that it was a magic drug. And we today say that it's completely useless. We know that it does not have a role for COVID-19. So this is a whole 180-degree turnaround, right? And that's happened not because there are competing interests or there's some sort of a nudge from any direction. It's just because this is how science progresses. So I can, the unfortunate part of this is that people tend to lose faith in the system. People tend to say, who do we trust? Doctors say something, somebody else says something else. Experts themselves are so confused. How is the average person supposed to get it right? So one of the things I would suggest is, hold on to some sort of a legitimate source of information. So there is the British Medical Journal, which, for example, updates its guidelines regularly. There's the World Health Organization. There's the CDC. There are multiple guidelines across the world, and if you find them at odds with each other, look for consistent features. So there may be some nuanced features where one guideline slightly differs from the other, but most of the look for what is consistent across. So if you look at the current guidelines, most of the guidelines do agree that inhaled steroids may have a role in the first week based on 2 studies which were recently done. Most of the guidelines will tell you that oral corticosteroids should not be given early. Steroids should not be given early. They should be given only when the oxygen levels drop. Most of the guidelines will tell you that plasma, for example, has no role in COVID now, or should not be used in the way it's being currently used. Most of the guidelines will tell you that remdesivir really may have a very limited role in COVID. So I think there is a consistency across most guidelines. When it comes to newer drugs, you might have a little bit of an inconsistency based on what professional bodies, the way they analyze literature. So what I would suggest is maybe hold on to 3 solid websites or 3 solid guidelines. And most of them nowadays are designed in a way that the average reader will also have a version that he or she can refer to. And just quickly go over those guidelines and see what most of the world is saying. We've been part of an initiative called indiacovidsos.org, and we've tried to create infographics which are plain, simple, which tell you what and again, these are people from across the world. So there is some consistency that people across the world sit together and agree on. So it's not I am saying this versus, I've heard patients telling me that aapka style alag hai, you treat differently. It's not a style, we are all following the science, and there is a consistency in the science that we all adhere to. And I think, going to trustworthy websites or trustworthy journals is possibly the best way to go forward.
As I say goodbye to you, do you have any word for viewers who are possibly watching this conversation but are Googling, self-diagnosing, self-medicating, doing sort of self-analysis about which state of COVID-19 they are in, etc.? Any word for them?
I think the word is a word of reassurance that most individuals do well. Unfortunately, when a disease sweeps through the population the way it is currently, the sheer numbers will make that small fraction of individuals who don't do well look like a really big number. And it is a really big number. But if you see that really big number as a percentage of all the people who've been infected, it's still about 10 to 15% of individuals who will see the inside of a hospital, who will unfortunately see the inside of an ICU, who will unfortunately pass away. So that number is a small fraction for a majority of individuals. And we need to be reassured in this statistic so that we don't panic, so that we don't make decisions that are counterintuitive or counterproductive to our health, that most individuals with COVID-19 will do well, will have a reasonably uneventful course, will recover and will move on with their lives.
Will move on with their lives. I think on that note, I'd like to thank you, Dr. Lance Pinto, for joining us, for answering all these questions. And thank you so much for your time. I know you have a busy day ahead, so thank you very much. Well, that's it then on this conversation of Newsworthy. Remember, if you have any questions, however small, basic they may be, just drop in it either in the comment section if you're watching this on YouTube or anywhere, whichever platform you're watching this on. We'll try and get you the best, most sound and calming and empathetic medical advice that we can. From our entire team, thank you for your time.